Welcome back to the deep dive. We're here to unpack the latest sources and give you those key insights. Today I'm just feeling really grateful for how far medical science has come. It's amazing what resources we have now to protect patients. And if this is your first time tuning in, a really warm welcome. We're glad to have you. For everyone returning, thank you so much for your support. It honestly helps us grow this learning community. If you like what you hear, maybe consider subscribing or sharing. So today we're diving into something super important for anyone in healthcare. Post-exposure prophylaxis for non-occupational HIV exposure, the CDC 2025 guidelines, our goal. To make sure you feel confident understanding these recommendations. We'll cover when PP is needed, the right meds, timing, follow-up counseling, all of it, right down to real-world cases.
Okay, so let's start with the basics. Non-occupational post-exposure prophylaxis, or nPEP, what is it? Well, it's basically using antiretroviral drugs after someone might have been exposed to HIV outside of work.
Like through sex or sharing needles.
Exactly. It's different from OPEP, occupational PEP, which is for, say, a needle stick in a hospital. Okay. And it's also different from pre-AP, pre-exposure prophylaxis, which is taking meds before potential exposure to prevent HIV in the first place. Okay. And the public health impact here is huge. I mean, new HIV infections have dropped dramatically since the 80s, down to about 32,800 in 2022. nPEP is definitely part of that success story. But the key thing, the absolute critical factor, timing. Speed is everything.
Okay, so let's picture this. A patient comes in, maybe they're really anxious after something happened. What's the checklist? When exactly do these 2025 guidelines say NP is indicated?
Right, so nPEP is recommended if there's been a non-occupational exposure, think contact with non-intact skin or mucous membranes within the last 72 hours. And critically, that exposure has to carry a substantial risk for HIV transmission.
Substantial risk, what defines that?
Usually it means the source person either has HIV and isn't virally suppressed, or you just don't know their status or suppression level. And several factors feed into that risk assessment. First, the source's HIV status. If you know the source has HIV, but they have sustained viral suppression.
Meaning treatment for over 6 months, good adherence, viral load under 200, or undetectable for the last year.
Exactly that. In that case, nPEP is not routinely recommended. Now, if you don't know their status, you have to assess case by case, and crucially, you don't wait to start nPEP while you investigate.
Don't delay. Got it. What if you find out later the source is negative?
Then you stop the nPEP. Simple as that.
Yeah.
Okay, next factor, the type of exposure. Appendix A and Table 2 in the guidelines lay this out. The highest risk is receptive anal intercourse, about 138 infections per 10,000 exposures.
Wow.
Yeah. The sharing injection drug gear, that's around 63 per 10,000. And even a needle stick outside of healthcare, about 23 per 10,000.
Right. Lower risk exposure.
Receptive vaginal sex is lower, maybe 8 per 10,000. Insertive vaginal sex, even lower, around 4 per 10,000. Yeah. And then there are exposures where nPEP is generally not needed unless there's something unusual going on, like oral sex without a condom, human bites unless there's clearly visible blood in the saliva, which is rare.
Kissing, mutual masturbation.
Right, or exposure to things like tears, sweat, urine, if there's no visible blood. Also, if a condom was used and didn't break, nPEP isn't recommended. And remember, the exposure has to involve broken skin or mucous membranes.
Okay. What else bumps up the risk?
Other STIs?
Yep.
Having another STI can definitely make HIV transmission more likely. Now, an interesting one. What if the person exposed is already taking pre-AP?
Good question. If they're taking it correctly.
Then nPEP is usually not recommended. Pre-AP works really well. But there are exceptions. Maybe they just started pre-AP and aren't fully protected yet, or they missed doses, or they're using some intermittent schedule that's not quite guideline approved, or potentially the source has HIV resistant to the pre-AP drugs. Then you might consider nPEP.
That's a lot of nuance. It really underscores the value of having backup, doesn't it? Like that National Clinician Consultation Center PAPE line.
Absolutely. That number again, 888-448-4911. Great resource for complex cases. Now, about that timing we mentioned, this is maybe the single most important point. HIV exposure is a medical emergency. You need to start anti-IR as soon as possible.
Immediately if you can.
Ideally, yes. Within 24 hours is best. But the absolute cutoff is 72 hours post-exposure.
And why that specific window?
It comes from studies, particularly in primates. They showed starting p-Hyme early, say 12 or 36 hours after exposure, stopped infection. But waiting until 72 hours, it didn't always work. The virus basically gets a foothold. Efficacy just drops off sharply the longer you wait.
Makes sense. So practically, how do we speed things up in the clinic?
The number one tip, Don't delay the first dose waiting for lab results. The only exception might be if a rapid HIV test is positive, then you need to confirm they don't already have HIV.
But otherwise, get that first dose in them.
Yes. Get the medication in their hand during that visit if possible, or at the very least, have a solid plan so they can get the prescription filled immediately after leaving.
Okay, but what if someone walks in late? Day 4, day 5? What then?
Yeah, that's tough. The guidelines say there isn't enough evidence to recommend nPEP after 72 hours, but as some experts do argue, it might still be worth considering, especially with the newer, safer drugs we have now. It's a bit of a gray area.
So what do you do?
You definitely still test them for HIV, provide really good prevention counseling, talk about pre-EP, and set up a clear follow-up plan. But routinely starting nPEP after 72 hours? No, that's not the recommendation. All right, let's talk regimens. The CDC guidelines recommend a 28-day course, and the preferred options for most adults and adolescents are pretty straightforward now.
Okay, what are they?
First choice is often bictegravir, intricidabine, and tenofovir alafenamide. That's the one pill, once-a-day regimen, brand name Biktarvy.
Biktarvy, got it.
The alternative preferred option is dolutegravir, combined with either tenofovir alafenamide, that's TAF, or tenofovir disoproxil fumarate, which is TDF. And you also add either emtricitabine or lamivudine.
So dolutegravir plus TAF or TDF plus intricidabine or lamivudine still sounds like a powerful combo.
It is. Both preferred options essentially combine two NRTIs, that's nucleoside reverse transcriptase inhibitors, with a second-generation NSTI, an integrase strand transfer inhibitor.
And the benefit of that combo?
High potency, a really good barrier against resistance developing, generally fewer side effects than older regimens, and they're convenient, often just one pill once a day. All that helps people actually stick with it for the full 28 days. But, it's not always one size fits all. There are situations where you need to consider alternatives, like drug interactions.
Right. What should we watch out for?
Big one is polyvalent cations. Think antacids or supplements with aluminum, calcium, iron, magnesium. They can bind to the NSTIs and mess with absorption. Always use a good drug interaction checker. The University of Liverpool is a great one online.
Any specific interactions to highlight?
Yeah, dolutegravir can decrease how the kidneys clear metformin. So if someone's on both, you need to limit the metformin dose, usually to 1 gram per day. Then there's kidney function. TDF, the older tenofovir, has been linked more with kidney issues than TAF. So if someone has moderate or severe renal impairment, you'll need dose adjustments or specific regimens laid out in Table 5.
And if their kidney functions are really poor, like CRCL under 30, and they're not on dialysis?
Definitely consult an HIV specialist.
Yeah.
Same goes for severe liver impairment, Child-Pugh Class C. Mild to moderate, Class A or B, is usually okay with standard doses. What about pregnancy or breastfeeding?
Ah, good question.
These are not reasons to withhold nPEP. You absolutely offer it. But you do need a pregnancy test for anyone of childbearing potential, and you have a careful discussion about risks and benefits.
Are there any drugs to avoid in pregnancy?
Yes. Certain boosted drugs like cobicistat-boosted atazanavir, darunavir, or elvidugravir aren't recommended due to limited data or potential lower effectiveness. And sometimes pregnancy changes how drugs are processed, so doses might need adjusting. You also need to counsel about potential infant exposure through breast milk.
Sounds like another case for expert consultation.
Definitely. The NCCC perinatal HIV line 888-448-8765 is invaluable here. Other special cases, kids. Pediatric dosing is different, based on age and weight that's in Table 4. For infants under 4 weeks, refer to specialists. Also consider someone's history with HIV meds, especially if they've had long-acting injectable cabotegravir, CABLA. Levels can linger for years and potentially signal resistance to NSTIs.
And if the source person has known drug resistance?
You need expert consultation to pick the right nPEP regimen. But again, don't delay that first dose while figuring it out. NSTIs are still generally preferred if resistance is a concern. And finally, just thinking about adherence. Pill burden, how often you take it, side effects, cost, access, all these things matter. Simpler is usually better for making sure people complete the course. Okay, let's shift to follow-up and monitoring. This is just as crucial as starting the meds. There's a specific lab schedule.
Right. What's needed at baseline before they even start?
You need an HIV test, either a rapid antigen antibody test, a lab-based one, or both. Now, if the person has had long-acting injectable PP within the last year, you also need a diagnostic HIV nucleic acid test, or NAT.
But you start the meds before getting results back, right?
Absolutely. Don't delay the meds for results. Other baseline tests: serum creatinine for kidney function, ALT and AST for liver enzymes, hepatitis B status, and a pregnancy test if applicable. And the counseling at that first visit is key. You have to explain that the initial HIV test can't detect an infection from this specific recent exposure. That's why follow-up testing is non-negotiable.
And tell them what to watch for.
Yes, educate them on acute HIV symptoms, fever, rash, flu-like feelings, and tell them to come back immediately if those occur. Now, for the follow-up HIV testing, because the nPEP drugs can suppress the virus and delay the antibody response, you need both a lab-based antigen antibody test and a diagnostic NAT for follow-up.
Not the oral rapid tests.
No, they're not sensitive enough for potentially acute or recent infection in this context. The timing. Do an antigen antibody test plus a NAT at 4 or 6 weeks after the exposure.
Is that always necessary?
Well, the guidelines say you might defer that 4 or 6 week test if nPEP was started super early, like within 24 hours, and the person was adherent, and they're not planning to start pre-P right away. But the final HIV test is essential for everyone. When's that? 12 weeks after the exposure. Use both the antigen-antibody combo test and a diagnostic HIV NAT. That timing accounts for the drugs washing out in the test window periods.
Okay, so that covers HIV testing. What about other monitoring? Those baseline labs like kidney and liver function?
You don't need to routinely repeat creatinine, ALT, or AST unless the baseline results were off or the patient develops new symptoms.
Makes sense. What about STIs? If someone's at risk for HIV, they're likely at risk for other things too.
Exactly. STI screening is crucial. Test for gonorrhea, chlamydia, syphilis based on the exposure type and their history. And importantly, the 2021 STI guidelines recommend presumptive treatment after a sexual assault.
Meaning treat them for likely STIs right away.
Yes, an empiric regimen covering chlamydia, gonorrhea, and trichomonas for women, chlamydia and gonorrhea for men. And for gay and bisexual men, you might also discuss doxy-PP, taking doxycycline after sex, to prevent bacterial STIs.
Good point. What about hepatitis?
Test for Hep B at baseline, mainly because some nPEP drugs, like tenofovir, emtricitabine, lamivudine, are also active against HPV. If someone has Hep B and stops these drugs, they could have a flare, so you need to know their status. Offer Hep B vaccination if needed, and also HPV or Mpox vaccines if indicated.
And managing side effects.
Definitely talk about potential side effects up front. Maybe offer anti-nausea meds just in case. Encourage patients to call if they experience anything bothersome. Open communication is key. So we know patient situations can be complex. Let's touch on a few special populations, pregnant or breastfeeding patients.
We mentioned NTP is okay, but what about the specifics?
Reiterate that it's offered when indicated. Decision-making around breastfeeding needs to be shared, discussing risks and benefits of continuing or pausing it while on nPEP. And again, that perinatal HIV hotline is there for consults. For adolescents and kids, be mindful of mandatory reporting laws for child abuse and state laws about minors consenting to care like STI treatment or HIV testing, PPPPP. Always use a trauma-informed approach, especially with assault survivors.
Right. And people with chronic Hep B or C.
If they have Hep B, choosing an nPEP regimen that also treats Hep B, like one with tenofovir and FTC or 3TC, might be preferred. But you need careful monitoring, especially when they stop nPEP because of that floor risk. For Hep C, just be aware that drug-induced liver injury might be more common, so expert input can be helpful. What about people who inject drugs or have substance use disorder?
Important group.
The good news is the preferred nPEP regimens don't interfere with methadone or buprenorphine, so no dose adjustments needed there. It's also a chance to discuss SUD treatment, safer injection practices, and offer naloxone.
And folks on hormone therapy.
Generally compatible. Preferred nPEP meds usually don't require dose adjustments for estrogen or testosterone therapy.
Okay, this all leads perfectly into counseling and adherence. Giving the pills is one thing, making sure they're taken correctly for 28 days is another. How do we support that?
Effective counseling is everything. You need to cover the benefits, the potential side effects, and really hammer home why completing that full 28-day course is so critical.
What are the absolute must-cover topics?
Explain their specific risk level. Review the timeline why starting ASP and taking it daily matters. Explain what the baseline and follow-up tests mean. What happens if a test is positive? Or if the source's status becomes known? Go over to drug interactions. What if they miss a dose? And importantly, how to recognize those acute HIV symptoms and when to call. And during that 28-day period, advise them on reducing any potential transmission risks themselves using condoms, not sharing needles, not donating blood or tissue.
How do you check in and support adherence?
A 24-hour follow-up call or visit is really recommended. Just to check, did they get meds? Are they tolerating them? Any issues with taking them? Then discuss practical aids, pill boxes, phone reminders, linking doses to daily routines like brushing teeth. A non-judgmental, trusting relationship makes a huge difference. We also have to talk about cost and access. These meds are expensive.
True. What can help?
Discuss manufacturer assistance programs. Generic options are becoming more available too, which helps. And clarify the prescription length. Sometimes pharmacies dispense 30 pills, but the course is only 28 days. Make sure they know when to stop. And for sexual assault survivors, this is particularly challenging. Adherence rates in studies are sometimes quite low.
That's concerning.
It is. So that empathetic, trauma-informed approach is vital. Setting up systems where they get the first dose immediately, and ideally the whole course or a starter pack right then and there, can make a big difference. Connect them with resources like forensic nurses or Ray and Anat.
Okay, let's make this really concrete. Can you walk us through a couple of scenarios?
Sure. Scenario 1. High-risk sexual exposure. Let's say someone had receptive anal sex. No condom, source unknown HIV status happened yesterday.
Okay. High risk, within the window.
Exactly. Risk assessment confirms high risk. Need to start nPEP immediately, preferred regimen. Biktarvy is a great choice, bictegravir trisodavine taf. 1 pill, once a day.
Counseling points.
Acute HIV symptoms, need for 28 days of adherence, follow-up testing schedule, then baseline labs, HIV test at 4 to 6 weeks and 12 weeks, plus STI screening. All right, scenario 2, injection drug use exposure with complications. Someone shared needles with a friend they know has HIV and isn't suppressed, so detectable viremia. And the person exposed also has chronic hepatitis B.
Okay, higher risk source plus the Hep B complication.
Right. Urgency is high. For the regimen, you need something active against Hep B, so maybe dolutegravir plus TDF and lamivudine. TDF and lamivudine both cover Hep B.
And monitoring.
You'd need that baseline HIV, kidney, liver, Hep B testing. But you'd also need closer monitoring for potential Hep B flares, especially after they finish the 28 days of nPEP. Counseling would cover adherence, but also harm reduction for drug use.
Excellent examples. This really helps tie it all together. So, wrapping up this deep dive on the 2025 CDC nPEP guidelines, what are the absolute core takeaways?
I'd say timing is paramount ASAP, within 72 hours. The recommended regimens are usually 3-drug and SDI-based combos like Biktarvy or dolutegravir setup. Adherence for the full 28 days is non-negotiable. And comprehensive follow-up with testing at baseline for 6 weeks and 12 weeks, plus SDF screening, is essential. And just the word of encouragement for all the clinicians listening, the work you do in HIV prevention, including using nPEP appropriately, makes a real difference. It's a safe, effective tool when used right.
Absolutely. And as we close, maybe something to think about. HIV prevention is evolving so fast. We're seeing things like PEP-in-pocket strategies being discussed, research into shorter nPEP courses, more long-acting options. How might these future tools change our approach and get us even closer to ending the HIV epidemic? Something to keep an eye on. Thank you so much for joining us for this deep dive. If it was helpful, please do subscribe, share it with colleagues, and keep learning with us.